Good evening, everybody. I'll give everybody a moment to make their way in. I know that we have quite a few people in the waiting room for tonight's presentation. I am super excited tonight because Mila is a classmate of mine from NECO, so it is very exciting to be moderating tonight. Hopefully we have some NECO attendees here tonight. I shared it on Instagram trying to get some of our classmates here. So if you're here from NECO, hi, we're excited to be here. So let's get started. Welcome to tonight's Woo You presentation, Keeping Up with Dry Eye Treatments in 2025 with Dr. Mila Yusufova. Thank you. And I'm your host, Dr. Jennifer Stewart. And thank you to Bausch& Lomb for exhibiting at this event. For each hour of CE, attendees must be online for a minimum of 50 minutes. For a COPE certificate, please fill out the survey link in the chat. The survey link will also appear when the webinar ends. CE certificates will be delivered by email and sent to ARVO with OE tracker numbers. We'll also display the QR code at the end of the event if you have the OE tracker app on your phone. CE certificates will be emailed within 4 weeks, and make sure to ask your questions using the Zoom on-screen floating panels. I believe we're also going to have 2 survey questions, so look for those to pop up as well. There'll be one at the beginning and one at the end. So here's where you can find chat and Q&A on your phone. And it's my great pleasure to introduce my wonderful classmate, Dr. Mila Yusufova, graduated with honors from the New England College of Optometry and completed a residency program in community health and ocular disease in Boston. She's a fellow of the American Academy of Optometry and is on the leadership team of the anterior segment of the AAO. She served as an adjunct clinical faculty at the Pacific University College of Optometry and was an examiner for the National Board of Examiners in Optometry. She's involved with her state association and advocacy efforts, and she's a director of education for the Oregon Optometric Physicians Association. She's a board-certified nutrition specialist and is a fellow and board member of the Ocular Wellness and Nutrition Society. She owns a private practice in Portland, Oregon, with special interest in advanced dry eye treatments, nutritional counseling, and aesthetic services. Welcome, Dr. Mila. This is your first Woo You, right?
It is. I'm so
Oh,
excited to be here.
well, welcome to the Woo You community. We're excited to have you, and I will see you at the end.
Thank you so much. I am super pumped. I'm super excited to be here, especially with my good friend Jen. And we are going to talk about all the new things, all the things that you've been hearing about, but what's also coming out in the pipeline for dry eye. It seems like it could be really overwhelming. There's so much information, so many treatments. Like, where do we start? So, I'm gonna hopefully make it easy for you to really understand and be very mindful with your treatment selection. So, as I said, it could be overwhelming. Do we start with eye drops? We have neurostimulators, nasal sprays, we have light-based therapies, then we have thermal treatments and biologics. We have amniotic membranes, and then we have blood biologics. So it could be really overwhelming. And for us to answer that question, like what is the treatment of choice? In order to do any treatment for any disease, we have to understand a disease, right? I know you've probably seen the DEWS 2 definition of dry eye a million times. Every dry eye speaker reads that through, so I won't read it for you this time. But TFAS DEWS 3 just came out a month ago. So I've been reading through it and looking for things that are different. And this I will read because there are some nuances. So for the most part, thank goodness, they've kept it the same. They're not like huge differences. But again, for us to kind of flow for the flow of the lecture to really understand why we're selecting the treatments, this is how I think of dry eye. So first I need to understand. So dry eye is a multifactorial symptomatic disease. So this is a new add-on, new addition to the definition is the symptomatic disease characterized by loss of homeostasis of the tear film and or ocular surface. So that part, ocular surface, has been also added to that loss of homeostasis, in which tear film instability and hyperosmolarity, that's the same, ocular surface inflammation, same as before, and neurosensory abnormalities take place. So as we go through the treatments, there are three things I want to focus on. So in the disease process, first we have tear film instability, hyperosmolarity. Then we develop inflammation. And then as a end stage, sort of more downstream problem is the neurosensory abnormalities. So that's how I think of the disease when I'm treating. I'm looking for those things. Where in the spectrum is my patient? Am I just focusing on stability of the tear film? Am I focusing on reducing inflammation, or do I need to heal the corneas? So again, symptomatic is the new addition to the definition. So let's talk about that for a second. So in order for us to label the condition dry eye disease, you have to have both signs and symptoms. And there are other conditions that can overlap with dry eye. We know that with patients that have symptoms, pain without stain, those neuropathic pain patients, they may start out as dry eye, but now they have this other condition that's associated with dry eye. So they can be, you can have both, but it's important for us to understand the other disease process. On the other end, if you have neurotrophic condition where you have the corneas look like a mess, there's a lot of signs for us to see, but symptomatically, patients report no symptoms. So again, this is a different condition, but it may start out as dry eye, and now it ends up being that because of the nerves that get damaged over time. So when we talk about symptoms, there is in DEWS 3, they highlighted this questionnaire OSDI 6. I personally have been using speed questionnaire in all of my dry eye patients. I actually do it on every single patient. So every single patient coming in fills out a speed questionnaire. We use electronic questionnaire, so they get emailed. These questionnaires get emailed to them, and they fill it out. So before they even come to the exam, I know if they are going to be a dry eye patient based on those speed scores. But what I like about the OSDI 6 is short. So is speed, but this particular one, if you look through the questions, they're not actually asking anything about dry eye. It's more vision related. So eyes that are sensitive to light, vision blurring between blinks, that's important one. Any basically fluctuations and how they feel in the wind and things like that. So I think that this is a really good questionnaire, and I'm definitely going to be switching from my speed question that I've been using to the OSDI 6 now that we have this new data from DEWS 3. So here's the algorithm that they laid out for us. So if your patient fills out, if their score 4 or more, then that would prompt you to look for some signs. So you want to look at the tear breakup time. If it's less than non-invasive tear breakup time is less than 10 seconds. If you're using fluorescein strips, not fluoresce, you don't want to numb the cornea, you don't want to flood the cornea. It should be if it's less than 5 seconds. Now they have the symptoms and the signs. Or you check the osmolarity levels, which as we know is in the definition of dry eye hyperosmolarity. So if their values are elevated over 308, or there's asymmetry between the two eyes of greater than 8, then that is ocular surface dry eye disease. And then also for staining, we want to be looking for corneal for any punctate staining, 5 spots or more, and conjunctival staining, and then also looking at the lid margins. So this is, again, going back to the definition, this is my thought process when I go through my treatment, choosing my treatments, is I want to first stabilize the tear film. So I want to, make sure that we can help to restore homeostasis. But if we're more in the disease or past that, or if the patient's had dry eye for a long time, I want to reduce inflammation. So that's the other thing. And the third thing that was in a definition was the neurosensory abnormality. So I want to heal the corneal nerves. So this is sort of like, I mean, there's more treatments that we can add to it, and I keep adding to this, but this is, if you like, if your brain kind of works like mine, thinking about, organizing, categorizing different treatments, this is where the treatments would fall. Now, a lot of these will have crossover to the other column. So it's not a hard line between, for example, IPL. When you do IPL, it can help with my meibomian gland function and improve the tear film stability, but it's also been shown to reduce inflammation. And if that reduces inflammation, we essentially we can help the corneas heal better. But on this column, we're all the treatments that are targeting MGD, the first one. In the middle, we have our immunomodulators, anti-inflammatories, against some of the other like in-office treatments. And then we have our biologics really fall under the healing the corneal nerves. So your membranes, your biologics. Okay, so how do we check the stability of the tear film? We have great devices looking at non-invasive tear breakup time with like keratograph, also using fluorescein strips. I love doing that. I stain every single patient. I do that before I do refraction. I want to make sure the corneas are nice and clear before I spend time refracting. I don't want to re-refract them, do any redos on glasses and things like that. So my step is always to do corneal checking the cornea before refracting. I don't really do Sherman strips, maybe for my autoimmune patients. If I'm co-managing with rheumatology, they'll want to know that lissamine green is very important for the conjunctival. And then tear lab osmolarity, that's something I've been utilizing a lot in my office for the last, here just showing that the filter really makes it pop, like the bottom filter picture is with the filter. But osmolarity is a very valuable test that we could do in office in a normal, healthy state. When the tear film is in a homeostasis, we have nice and healthy tear film, everything is in balance. When there's loss of homeostasis, when there's desiccating stress on the ocular surface, now we have these hyperosmolar tears, so they're kind of toxic to the ocular surface. So I explain this to patients, like the chemistry, the composition of your tears changes. They become more salty, right? So over time, that hyperosmolar tears become more toxic to the ocular surface and then break down the epithelium. So again, values are important. Patients like numbers. So this is another way to show them maybe from visit to visit, or after doing treatments, after doing IPL treatment, or if you're putting them on prescription eye drops, how those numbers are improving and what your visit to visit variability is. So we want it to be normal, flat line and not so like zigzaggy from visit to visit. It also can help to differentiate some of the other conditions that could be mimicking dry eye, like CCH, like allergies, EBMD, and things like that. So once you establish that patient has poor unstable tear film, the next thing is to figure out why, right? So looking at the meibomian glands. Meibomian gland evaluation should consist of two parts. One is looking at structural changes, and that you can do with meibography if you have that in your office. I do meibography on every single patient. I'm not just doing it on symptomatic patients. And then the next thing is and that's a great tool because then you can show them the normal and how it's changing, or how it compares to what their glands look like, and not how that compares to the normal glands. If you don't have that, you can use a transilluminator on the eyelid, where you can put the light on the outside, flip the lid, and you could visualize the gland structures and see how long they are, if they're truncated, dilated, and things like that. But it's also very important to check the function of the glands. So you can't just do images of the glands and they could look beautiful, they could look normal, but if you push on them and nothing comes out, it's really thick and inspissated oil, then that's problematic too. So it's not just how they look on images, or how they look in the slit lamp, it's how they function, what kind of oil they're producing. So this is what I do on every single patient, not just my dry eye patients. I have this tool, my meibomian gland evaluator. I'm pushing on 3 sections on the lower lid. I'm looking at um, I'm looking for clear oil, and I'm documenting, is it clear, is it inspissated mix, or is it thick, like toothpaste like. And anything 5 or 6 glands or less, that's MGD. You got to be aggressive, you got to treat the disease. If it's around 6 to 10, borderline, you may be doing some at-home treatments, and then anything 12 or above is considered normal. Okay, now that we've determined the patient has MGD, what do we do next? There are in-office treatments. Again, home treatments is I I find those I specialize in dry eye, so I get a lot of referrals. By the time patients come to me, they've tried all the warm compresses, they've tried over-the-counter drops. So I really don't spend too much time doing those things. I want to get the results. So I go straight for the in-office treatments. So we have thermal heating procedures. This involves inside or like internal lid treatment, like LipiFlow, which is automated, or iLux, which takes a little bit of more technical, doctor or technician has to perform it. And we then have external heating devices. We have um, uh, tear care, and then also MIBO, and then some other basically smaller handheld. And within the same category falls radio frequency. Radio frequency, there is not direct heat on the lids. It's actually electrical current that we send, and there are two different types. There's monopolar and bipolar. With monopolar, we have to have grounding pads, and the signal, this current, the electrical current, goes between the probe and the grounding pad. As a result, the this current goes a lot deeper. So for aesthetic results, we actually see pretty good, better results with this method with the monopolar versus the bipolar. Bipolar is more superficial. It's not as long lasting as far as getting like the anti-wrinkle effects. But for our purposes, because the current actually heats up the glands or the tissue to 42.5 degree, we can melt, liquefy the meibum. So that's how we're utilizing these tools, RF, radio frequency, for MGD treatment. On the other hand, we have some treatments that specifically help with photobiomodulation. We'll talk a little bit about that. We have intense pulse light, there are different brands, and then we have low level light. Whichever method we're doing, the goal is to liquefy oil and then express and evacuate that. And there are different tools. I like the flat one, with the round edge expressor for the top lids. More of the flat ones I use for the bottom lids. And I like to actually hold it vertically. These pictures I took were horizontal, and then I kind of go horizontal and then vertical. And then this picture shows the neurostimulator, the external neurostimulator, which we'll briefly talk about that. Because it actually stimulates the meibomian glands. I learned this from Dr. Laura Perriman, so I gotta give her credit for it. It stimulates the meibomian gland, so that makes the expression even better. So after you've heated or done whatever treatment you're doing, RF or IPL, and then add this to your expression process before you express, and that really helps to get those oils going. Okay, what would you do in this case? When you see eyelids like this, would you be doing RF on this patient? Would you be doing LipiFlow, tear care, or any of the thermal devices? I hope you could see and appreciate how inflamed those lids are, how telangiectatic, and there's a lot of biofilm and blepharitis, so we won't talk about that yet. But ultimately, these lids need more of a light-based treatment. Ocular rosacea and MGD, there's a strong correlation, especially if you have a patient who has facial rosacea. 80 to 9% of those patients will have ocular rosacea. So if you see a patient across the room with red cheeks and red nose and chin, then you better assume that they're going to have ocular rosacea and they're going to have MGD and probably blepharitis. Ocular rosacea can precede facial rosacea in about 15 to 20% of the patients. So these are classic examples. These are my patients. Look at all that telangiectatic blood vessels. Those glands are not going to respond to just heat. We got to reduce that inflammation. We got to target those blood vessels, and then target that. And 80% of rosacea patients have meibomian gland dysfunction. So there's a strong, strong correlation. IPL has been around for a long time now. So again, probably don't need to spend a whole lot of time on this. I've been doing IPL for the last 8 years. We just got our second one. It's one of our best treatments that we do. It's, targeting chromophores in the skin, melanin, hemoglobin, water, depending on which wavelength we use the filters, then we target different tissues. And it's important to know that we're not targeting the normal deeper blood vessels. These are the abnormal superficial blood vessels that are telangiectatic. And those are the ones that are leaky. So different protocols. FDA approval is from tragus to tragus with the OptiPen, OptiLight. With the pen, you can go closer, but not directly on the lids. However, off-label way of doing it is the Perriman protocol, and that's what I've been doing for the last 8 years with the corneal shields. And you're still doing tragus to tragus, but then you directly go over the lids. And then, of course, expressing the glands afterwards. What I love about IPL is that it doesn't just have like one mode of action. It does so much, which is why again we're so successful with using this for a lot of our dry eye patients. It has photocoagulation of the abnormal telangiectatic blood vessels. So again, we're not targeting the deeper blood vessels. These are the visible surface blood vessels. Those are abnormal. It has photobiomodulation of the meibomian glands. What does that mean? So it's used in this term is used, excuse me, used in aesthetics a lot for skin rejuvenation. And essentially, the mitochondria of the cells absorb the light. And we see this with red light therapy a lot too. So for glands that are sort of destined to atrophy at this point, they may function better. I never use the word regenerate. I'm very careful with that with patients, but ultimately they do look sometimes better, and they look like they're now totally full of meibum, and they're now like functioning where they looked weak, kind of lighter in the past before the treatment. It also decreases overactive skin cell turnover, and this is something we see in our blood vessel or patients with rosacea. You see all that scallop lid margins, a lot of hyperkeratinized skin on the eyelids. It has antibacterial and anti-Demodex effects, and it reduces inflammation. It's been shown to reduce inflammatory mediators. Here's an example of how else we could use. So this is a patient who had a chalasia that was just not going down with warm compresses. Luckily, she came to us soonish. It was about like less than 2 weeks, and in only one treatment got rid of it. This patient, however, was referred to me. She had been struggling with it for over a month and a month and a half. And it took 3 treatments for hers to go down. But look how massive it was. And these patients just wanted to avoid any surgery. This is my eye. I had an internal hordeolum that was turning into a preseptal cellulitis. And I did a treatment, and within 2 days it was resolved. So I was able to avoid oral antibiotics. Another condition that's really important to keep in mind, Demodex is very prevalent in your rosacea patients. 80% of your patients with papulopustular rosacea, it's that acne-like, those bumpy rosacea, will have Demodex, not only just on their eyelids, but it's probably on their face as well, which is why they have those breakouts. And 51% of patients with erythema telangiectatic, that's the more generalized redness, those are the patients that have a little bit less, but still you'll see Demodex in those patients. So very easy to diagnose. You have the patient look down, you look for collarettes, those sleeves around each latch. And if you're want to really have fun with your patient, you can get this $200 microscope on Amazon and epilate an eyelash and show them their Demodex, which I like to do and freak out my patients. And now we have a great medication that targets these mites really well. Their clinical trials showed 50% of complete resolution in 50% of the patients, and 85% showed meaningful reduction in collarettes, so going from higher grade to lower grade. So that's, in my practice, has been one of the best treatments that's come out as far as the pharmaceutical goes. And it also has been shown to reduce inflammation on the eyelids too. So even if I'm about to do treatment, I'd like to put patients on lotilaner on Xdemvy, and it's a twice a day 6-week course. Sometimes we'll do 2 courses back to back, but you'll see also reduction on the eyelids, and meibomian gland function will improve as well. So moving on, or going back to, we're still talking about stabilizing the tear film. So we're still on the first level, which I think is the biggest. As we know, meibomian gland dysfunction makes up majority of dry eye. So that's why we're spending a lot of time talking about all the different treatments. So this is from DEUCE 3. new image, kind of putting it all together, all the things that you want to look for. So of course, again, have the patient look down. You want to look at any redness, any blepharitis, telangiectasia, and then have them look up. Pull on the eyelids to check for any eyelid laxity. So I'll show you examples of that, but ultimately, really spend some time on evaluating the eyelid, not just what's going on, whether it's red inflamed or there's Demodex or blepharitis, but also structural changes. Are the eyelids closing all the way? Is the patient blinking completely? So I have them sit behind the slit lamp and I just have them blink normally. I don't tell them to do anything and I just observe. Are they blinking fully or do they have these incomplete blinks? And sometimes they just stare. They're not blinking. So I'm like, all right, corneal nerves are damaged here. So one of the things that's been also huge is checking, incorporating eyelid closure. So if your patient is complaining about morning symptom, always ask your patients that question: How do your eyes feel in the mornings? And then just have this simple cord Blackie test where you have them look or close their eyes. I tell them to just close your eyes like you're sleeping, so that way they're not just forcefully closing, and then you just shine a light. If you see any light coming through, that's incomplete eyelid seal. And it's not necessarily like ophthalmos. This is actually where you kind of have like an overbite and the lid is just not anatomically coming into that full contact. And these eyelid seals, sleep tight, sleep right, have been a huge help for these patients because they don't do well with ointment and they may do okay with moisture chamber goggles, but this is another nice option because not everybody likes having those things, especially if they have sleep apnea and they already have other devices on their face, they don't want to have a mask. Okay, so here's one of the exciting new treatments that's come out: dynamic muscle stimulation, DMST, and this is particularly so. The company that has the device for eyes is Luminous, and they have it for the eye portion. The device that I have, which I'll show you a video, is actually showing it's the full face. It's called TriLift. So this is a non-invasive electrical stimulation. It targets periorbital muscles, especially the lower lid, to tighten it. So RF works on the skin, causes fibroblasts, collagen formation, elastin formation, so it helps with wrinkles, tightening the skin. But what's more important for the lid laxity is the muscle, because that's what's holding the skin up. So targeting muscle is crucial. So in this is my patient. She's actually quite young and she has that really poor lid laxity. I see this in patients who are going through weight loss. So obviously in older patients and patients with like with sleep apnea, those are obvious ones. But with the younger ones, this particular patient has eating disorder, so her weight fluctuates a lot, so she loses a lot of volume. And not only it's important for the exposure reason, but as we know, if you look at this video playing on the bottom, it's the eyelid function is important, or the gland function. It depends on how well the eyelids come into contact. So you have to have that nice, full, strong blink for those glands to get contracted, or their muscles around them to kind of squeeze those glands and release the oil. So you can do a lot of things on meibomian gland function treatments, but if you're not addressing the function of the eyelids, then we may just kind of go in circles, right? And there are some essentially new or the small studies that have shown that this DMST has shown to reduce eyelid laxity, increase blink quality and rate, and improve dry eye symptoms. So here's a treatment on myself. And I want to make sure that the sound is off. And so the device I have is TriLift, and you can see my eyelid twitching. So the TriLift device has three hand pieces. So I'm using the small one, or my esthetician is using the small one for my eyelids. And you can see all that contraction, all that tightening of my muscles. And so that's on the periorbital area. And then this is now see that it's a bigger, much bigger handpiece, and now she's using it on my facial muscle, on my cheeks, and that you could really see my whole face twitching. It's kind of a crazy feeling. So here are the results. So this is a patient. Obviously, the corneas are still a mess, but we're making some progress. We're making improvements. So this is her where her eyelid was sitting. You could see it's quite low. We wanted to be closer to the lower limbus, and after tri-lift, we're getting there. It's improved quite a bit. Then this patient is much older. I think the first one is in her 50s. The second one is in her 70s. And I was like, I don't know how much, she kind of is closer to the surgical case, but she was not interested in surgery. So she's like, I'll try it. And you can really see how much we've lifted that lower lid, and it's very close to being normal. And look at all that SBK improvement. So again, as we improve, we're bringing the lower lid higher. We have a better blink, we have a better coverage on the cornea, and her SBK increased significantly. Okay, here's my picture. Look how old and tired I look on the left picture. That was just from a few months ago. And it's again, it just because I used my full face treatment, it just lifted my cheeks, and that helps with the whole, stability of the lower lid. So I do encourage, which is why I got Tri-Lift. I know the OptiLift is great. It's for the eyes. You could probably use the smaller handpiece for the face, but I opted to do the Tri-Lift because I want the full. I do, we also have aesthetic services. So for me, it made sense, but for some offices, it may try the OptiLift may be just enough because it targets the lids alone. Here's another new treatment. It's called Tixel. This is a thermomechanical action. It's really interesting. It uses this heated pyramid-shaped titanium pins. They're not sharp pins. So, but they basically have this stamping effect, and you could treat the eyelid without any shields. Here's a video on the right lower of treatment we were doing on a patient, and you could kind of see it just sort of stamps. We did use numbing on him, so we did numb, but some depending on the levels or how aggressive you want to do, you don't have to numb necessarily. And some studies again showing that Tixel essentially it all of these devices come to us from aesthetics, right? So it has all the aesthetic benefits, skin tightening. Again, it can help with eyelid hooding or like laxity on the skin, so wrinkles and things like that. But essentially, the thermal mechanical action, it does produce enough heat to melt meibomian so you could do your expressions. And some early studies show that there's improved meibomian gland function and reducing inflammation and then improving tear stability. But let's say that you've done everything and the patient is still very symptomatic and you're still struggling to get things under control. What do we do next? And this may be a case where there is now fibrotic periductal fibrosis happening with chronic inflammation on the eyelids. We can develop this fibrosis around the glands. And this is when I opt to do intraductal probing. So probing is this tiny 76 micron thin probes, and we're basically trying to break through that fibrotic tissue inside of the glands. Here's a video of me doing it. I like to use the meibomian gland expressor just for stability, and this is just using a 2 millimeter one. And essentially, I start with 1 millimeter and then go up to 2 or 4. We could do topical lidocaine for these patients. I've only had to inject one patient with injectable lidocaine because he just couldn't handle it. And if I have to do 4 millimeter, which is rare, then definitely use injected with lidocaine. And then afterwards, we put him on antibiotic steroid for about a week. Okay, so we're moving fast. It's a lot of information, but another new device. So actually, I'm gonna skip over. Well, let me briefly talk about biofilm. Biofilm is not new. We've heard about biofilm being a problem in MGD, anterior and posterior blepharitis. So blepharoexfoliation, we use BlephX or Zest. And another device that's really nice to pair with that is Rinsada, where we actually basically rinse out all the gunk that came out of the lid. So I like to do this with after doing those treatments, or sometimes even with other gland expression treatments. But what's exciting and new device is this Optimize device, which is consists of this control panel and also an applicator that's a contact lens type of applicator, similar to like a LipiFlow type of applicator. And essentially, it's a biofilm buster. It's crazy, but it makes a lot of sense. So now we believe that the biofilm is not just on the lid margins, it's actually inside of the gland. So what it does, it sends this electric current to the eyelid, and it's just kind of like vibrating. I think of it as like ultrasound cleaners, those cleaners that where we put our frames or jewelry and you see all the gunk come out of it. Kind of that's what it's doing on the eyelids. And then afterwards you express and you exfoliate and express. I am I just bought this, so I don't have any hands-on experience with it yet. I am getting my training next month. So if I'm invited to come back to a university and talk more about these new devices, I will report to you on my experience. But there is a new medication that's in the pipeline. It's a selenium sulfate. Basically, it's a keratolytic. It is designed to break the keratin probes, keratin plugs on the, and the clinical data looks good. I'm not sure when it's coming out, but I think it's soon. So the neurostimulation, we're still talking with stabilizing the tear film. So these fall into that where we're trying to get the basal tears to improve naturally. So we're trying to increase natural tear production. We've had a couple different ones. True Tear that was discontinuing. iTear 100 is what I showed you earlier that I use in my office with expressions. This is the external neurostimulation of the nasal ethmoid branch of the trigeminal nerve, and we're basically trying to get access, like backdoor access to the lacrimal functional unit. So we're increasing the um, we're increasing stimulation to lacrimal glands, to meibomian glands, and to goblet cells. And we do have another. So the neurostim the 100 iTear 100 is the mechanical stimulation, and then we have the pharmacological, which is Tyrvaya. So again, the video sort of shows how we are bypassing that afferent signals and we are going through the nasal stimulation to increase natural tear production. So a new medication that's kind of in line with that is Triptyr, which is a new drug that just got approved, and they're about to. We're going to be able to prescribe it next month, so it's going to be available very soon. So this is an agonist of specific receptors, TRPM8, which we have on our eyelids and our cornea. So these are they're temperature receptors. So, and by using this drug, we are stimulating basal tears, or we are stimulating all the glands to increase tear stimulation. So exciting, another, option for our patients. But what has been really impressive and really successful treatment for my patients is perfluorohexyl This is again for stabilizing the tear film. So this is a unique one ingredient formulation. So it's Mibo is the brand name that has no other ingredients. There's no preservatives. There's no vehicle or carrier. The whole thing is just that medication. And if you look at compared to the other lipid-based, just over-the-counter drops, because some patients will be like, well, how is it different from that? Well, you could see how much more it has that evaporation rate reduction of evaporation. So basically mimics our Mybom, and when you put a drop in the eye, it creates this monolayer on the ocular surface and sort of seals the ocular surface and protects it and helps to stabilize the homeostasis. I gotta keep going kind of fast because We have a lot more to go through, but the Lacrophil is another great one. It's a canalicular gel. It's hyaluronic acid. Again, helps to keep more tears in the eyes. And this is something that I like to implement. Maybe not right away, once I make sure that the inflammation is down, but it's been a great tool, way better than the plugs that we had before. So everything so far we talked about is the tear film stability. Now let's talk about reducing inflammation. We have corticosteroids, nothing new there. Cyclosporin. Cyclosporin is amazing, but it's very finicky molecule. So my choice of cyclosporin is 0.09 in the N cell technology. So that's the one that gets to the tissue faster because cyclosporin is hydrophobic, so it doesn't like to be on the ocular surface. Lefitegrast is also another great option. It blocks the active or and inactive T cells and reduces inflammation. So we have to have inflammatory control. And don't forget about IPL that's been shown to reduce inflammation. But the new medication that's as didn't get the approval just when they expected, but they reapplied and hoping to get the approval by the end of the year is Ripraxilab, and this is small molecule that binds to reactive aldehyde species. So before inflammation happens, we have these increased reactive oxygen and aldehyde species on the surface. So basically, this is like up upstream treatment to reduce any inflammation or even stop it from happening. Other anti-inflammatory antioxidants in the pipeline. So we're going to have a lot more options in that area. So that's exciting. So we are now down to the corneal nerves. So we talked about stabilizing the tear film, we talked about reducing inflammation, and then now we're talking about the corneal nerves. Corneal nerves are very essential in the whole homeostasis of the ocular surface, right? So they're involved in epithelial healing, they're involved in the reflex, in blinking, in tear production. So without the corneal nerves, the whole system, the lacrimal functional unit, is disrupted. So it's important that we take the time to assess that. I do corneal nerve sensitivity testing on all of my dry eye patients, and I'm a nerd. I like to measure things, so I have the Cochet-Bonnet and Brill aesthesiometer. So those are the tests that give you quantitative measures so that you can measure how reduced the corneal sensitivity is. And then on the other end, if you don't want to invest in those as technologies, all you need is a cotton tip applicator, just wisp it out, or dental floss, just don't use mint. And all you have to do is check four quadrants and centrally and report or record whether it's reduced or not. So that gives you more of a qualitative measures. The reason why it's important for us to do that, because dry eye, as it gets worse, now we're dealing with neurotrophic keratitis. So you may start with artificial tears, but now if you see that central SBK that's not healing, you got to initiate some cryopreserved amniotic membrane, autologous serum, or PRP. And as the disease progresses, we really want to avoid getting to stage 3 neurotrophic keratitis where the corneal neurotization or tarsorrhaphy may be needed. So this is sort of how I start. I'll start on cryopreserved amniotic membrane, which is my choice, my amniotic membrane of choice. I don't like dehydrated ones. I haven't had as good of a success with those, so I go with the cryopreserved. And then I keep them on autologous serum, and then, or as if the disease is progressing, or sometimes I'll initiate even before, where I do the oxyrate nerve growth factor. So here's an example of how I combined all of the treatments in as far as the biologics go. The patient was referred to me. This patient actually had no symptoms of dry eye because she had no feeling in her eyes. She came to me or referred because her vision was so blurred. She couldn't drive anymore. She was really relying on other people to get her around. So she was coming in 2070. We started her on oxyrate right away. Her vision improved to 2025. And then once she was finished, and then one of her follow-ups back a month later after she was done, her vision was starting to regress again to 2050. Then we put Procare. So sometimes I'll do, this patient actually lives like 3 hours away from me. So normally I would actually start with Procare as I'm waiting for oxybate approval. But in this case, because of the distance, we sort of started with that. And then when she came back, we did Procare because the vision was getting worse again. And then her vision improved to 20/40. And then after that, this is progression of visits over a year, right? So she now was again getting bad a little bit. We started on PRP, platelet-rich plasma drops. Her vision improved to 20/30. And then we've been able to keep her 20/30 to 20/25 vision with autologous serum 50%. So those are the ways that we can again combine all of the biologics to really keep patients stable and without having to regress. So we do autologous PRP and autologous serum drops in our office. This is me drawing blood. I have phlebotomy license, but now I have my esthetician, one of my estheticians who is now also a phlebotomist. So she does the blood draws and does the preparation. So there are autologous serum has been around for a long time. The difference is that this blood we use tubes that have clotting agents. So we coagulate the blood and then we spin it, and that separates the serum part. And then serum tends to be the whole process also degranulates platelets. So you do get growth factors from that process, but also that process can degranulate white blood cells. So you also get some pro-inflammatory mediators with it. Also, TGF beta growth factor is 5 times higher in autologous serum than it is in natural tears, and at a higher concentration like that, it has more of an anti-proliferative and pro-fibrotic effects, which is why we typically dilute serum to 20 to 50% concentration. Now, PRP and PRGF is different. So PRGF is plasma rich in growth factors, and PRP is platelet rich plasma. Slightly different preparation method. So one is single spin, the other one is more is double spin because we want to be more concentrated. And with the PRGF, we actually get the plasma or the platelets to get activated versus with PRP, we don't. So again, different methods of preparing. There's really no standardized, there's so many different ways of preparing it. And depending on the patient's severity of the disease is again, I may choose one treatment over the other. But PRP has been around in dermatology, aesthetics, dentistry for a long time. It has a lot of anti-inflammatory, it has regenerative effects. So again, it's really such a potent and natural way to treat disease. And in eye care, it's now becoming more popular over the autologous serum because it has a higher concentration of specific growth factors. So we have patients use it about 4 times a day, sometimes a little bit more, and they want to keep it in a refrigerator for up to a week and in a freezer up to 3 months. And you want to avoid UV exposure because you don't want to denature the platelets. So when we compare side by side, this is the $1 million question, which one is better? A lot of studies that didn't really compare apples to apples comparison, but this study did look at 100% PRP and 100% autologous serum, and they did show that both groups did improve in all the signs and symptoms, but best corrected vision improvement and OSDI scores were more significant in the PRP. So I think they both have a place, but PRP may be more helpful for some patients, especially if we are trying to concentrate the nerve growth factor. So if you look at the nerve growth factor, it's 10 times more in the PRP than it is in autologous serum. And as you know, uh, the endogenous nerve growth factor is responsible for um, essentially keeping everything working on the ocular surface for tear secretion, cell proliferation, corneal innervation, and basically healing the epithelial cells and getting back to homeostasis. So oxybate is been around. It's great. I utilize it quite a bit. It's 6 times a day. At every 2 hour intervals for 8 weeks. And again, usually I haven't actually had to do too many multiple treatments because I do keep him on other treatments. Okay, I know I'm like speeding so fast because I wanted to cover it all. There's so much great information. So I wish this was a 2 hour lecture because there's so much more I could say about like lifestyle. And this is the again TIFA's dues, sort of looking at the risk factors, how they presented, um, all the categories of different risk factors, which are consistent, non-modifiable, modifiable, and probable. So I, as a certified nutrition specialist, spent a lot of time about lifestyle and sleep, stress management, and dietary changes and things like that, because obviously that's huge. But a couple of things I want to highlight because we don't have time to get into the whole thing is the probable deficiencies and consistent deficiencies. So vitamin omega-3, so when it comes to macronutrients, omega-3 fatty acid deficiency has been proven over and over to be a risk factor for dry eye. So this it's important that we still educate patients on omega-3 supplementation. And if you really want to be precise about like who goes on supplementation, because if we're getting it enough from our diet, you really don't need to supplement, right? That's what supplementation is, to supplement what you're missing. So in our office, we do this finger prick test with the omega-3 index test, which is with this Omega Quant is the brand, is the company that offers this. So we take a finger prick test and send it to the lab, and we get the results. This particular patient was already on omega-3s, and didn't know which brand, probably Costco brand or something. So it's helpful for us to measure because then you can change it. Then the patient is more likely to be compliant with your particular recommendation of fish oil and not just continue to take what they're taking because obviously it's not doing anything at that level. When it comes to my micronutrient deficiencies, vitamin A, B12, C, and vitamin D deficiencies have all been shown to be important, or they're linked to dry eye. Again, I normally, when I talk about nutrition lifestyle, I go into each of these separately, talk about it and who's at risk, but I'm just gonna go straight to vitamin D deficiency because that's an important one. It is so important in our innate and adaptive immunity. It helps with reducing corneal inflammation. It helps to downregulate the pro-inflammatory mediators on the ocular surface. And overall, like especially patients with autoimmune conditions, vitamin D levels have to be optimized for sure. These are my dry eye patients. Again, examples of the vitamin D results from my clinic. Look at this, 27. Um, some of these patients were on vitamin D, but very low dose. 19. I live in Portland, Oregon, so Pacific Northwest. We don't get any sun like 9 months at a time. So a lot of my patients are very, very deficient. But then you can see on the flip side, vitamin D is fat soluble, so you can have toxic levels of vitamin D. And this particular patient was put on vitamin D level by her primary care doctor and supplements by her PCP, and then never readjusted, never retested. So she was actually at the really, really high levels where I had to take her off vitamin D and then kind of readjusted. Okay. Um, we're at the end. We're at the end. We made it. Dry eye. I just want to conclude with this that it's multifactorial, but it doesn't have to be overwhelming. We have, again, if you think about the dry eye, the definition, and then choose the test to help with the specific stages of dry eye. So is it the tear film instability that you want to improve? Maybe put him on MIBO, or while you're doing other like in-office treatments, you want to make sure the corneal surface inflammation is reduced because that causes damage and that causes neurosensory abnormalities. So always check corneal sensitivity as well, because if that's not working, nothing is going to be working. So if the corneal nerves are damaged and they're not functioning, the whole functional unit is disrupted.